Okay, we're recording this session and there are 4 participants, I'll just admit them all. Okay. All right, we've got all the participants joined now. Hello, can you all hear me? Okay, can you see the rest of the participants? I don't know, I can or not can. I think they have probably joined. They probably have got their video off. That's why I can't see anyone. So we'll just start the session in the interest of the time. Dr. Avda, can you hear me clearly? There was someone there and then, okay, never mind. We'll just start. So hello and welcome. We just going a trial class of our AMC Clinical course. And we're just going to go through some of the cases and highlight some of the aspects of our course, which is going to start February. But this is the first session in which we just basically give you an introduction to our sessions and how they are organized and answer any questions if you may have. So let's just start through it because we've got a fair bit of ground to cover. So first of all, I'll welcome you all and thank you, Dr. Ali, Dr. Zoe, and Dr. Ruhi for joining. Right now, I'm not in Sydney, I'm in Pakistan. So that's why, my internet might be a bit patchy. That's why, in fact, what I should do, Dr. Ruhi, make you an admin. So, okay. So if there's any hiccups, then you can take over if that's okay.
Okay, sir.
Okay. So continue running the session and you've got access to the slides as well. So you can pretty much let those. So that's because my internet has been very unstable. So today's session is all about our course, which we're going to be starting now. We're going to be doing our course in 2. So there's a lot of noise coming from in the background. So if somebody has got their mic on, if they can mute themselves, that'll help, improve the experience of the others and create that disturbance. Thank you very much. Thank you very much. All right. So in this session, we're just going to be talking about our cases and our session, how we run them, and what's the strategy behind them. I'm going to keep it very, very simple because I like keeping things simple. And I think if anything which likes to stay with you, which would stay with you, is the simplicity. So the way that I've organized this session is that we're going to be talking about why should you consider doing the AMC Clinical and some of the tips around taking the history, and then talk about some of the communication issues which are specific to this exam and what is it meant by, rapport building and how you should tackle some of the tough questions. And then I'll also give you an introduction to our portal where there seems to be a lot of questions around what have you got in your portal, how the notes and videos are organized. So hopefully I would be able to take you live through our software. And then, our lovely tutors have prepared some sessions, so we'll go through that. Finally, if you've got any questions, I'm more than happy and the tutors are happy. But before I start doing that, I'll get our tutors to just quickly introduce, starting with Dr. Ruhi.
Hello, everyone. I'm one of the tutor who is going to be helping you for MC preparation. So I will be doing mostly evening sessions. And yeah, that's it.
So thank you. Yes, you've been around with us for a while, Dr. Ruhi, and I like your strategy. Very clear and very specific to the point.
Yeah, so I will be there with you till you pass your exam. If you have any doubt, you can keep on asking in the group. So I will try to solve it. And that's it. Thank you so much.
All right. And Dr. Zoe, please.
Hello, everyone. My name is Zoe, and I also cleared the AMC Step 2 last year. And I'm new for the team of Dr. Rizwan, but I'm happy to show how the strategy that helped me with the exam.
Yes.
And yeah, thank you so much. Yeah.
Excellent. So Dr. Zoe would be doing also a combination of morning and evening sessions. And finally, Dr. Ellie.
Hello, everyone. I'm also one of the IMGs that recently passed my exam in the last October, and I'm the new tutor and mostly doing morning sessions. I try my best to help you.
So, Dr. Ellie, tell me, what did you find in your exam which was quite unique about this exam? Anything which, how did you do your exam online, in person? How was it for you?
I did it face to face, and I think the most important thing that it helped me to pass this exam was communication skills. I worked a lot in this, and because I'm working in the hospital and speak a lot with the patients, I try to communicate more with them. And I think in my exam that helped me a lot.
I think that's a very good tip. Dr. Zoe, what do you think? You probably might have done your exam online. What do you think that helped you most in your strategy in terms of passing the exam?
So I changed my focus on the differential. So whenever we have exam, we clearly have the working diagnosis that we cover enough recall. So it's not about the challenge to get the working diagnosis, but show the examiner how we get the working diagnosis and do our differentials. So
That's a
it's
very
a big
good point.
change to me. Yeah.
That's all about being a safe doctor. Yes, AMC clinical exam is about safety, making sure your knowledge reflects that broadness of your cases in terms of differentials, so that they know that you've got depth and the breadth across the cases, so that you're demonstrating yourself to be safe. Dr. Ruhi, you've been not only teaching, but you've also passed the exam. Can you share some of the unique tips? With the fact that you worked with lots of candidates as well in the recent.
I think knowledge is there with everyone, but it's very important to organize time and follow the structure. And I think this is the best platform for that, because we are following the structure and we are helping you to follow the structure from day one. And apart from that, I think it's very important to be very confident during the exam. From the first case itself. So be calm and confident and have a good sleep day before. So that is going to be really helpful. Confidence.
I think that's confidence is the key. So the time to focus is on communication, the breadth and the depth of your knowledge, as Dr. Zoe said, and be confident. Even if you're fluking, be confident in your flukes as well. All right. Okay. Excellent. So without further ado, let me just give you some of my personal insights. I believe AMC clinical exam is quite unique. And I like people who have done AMC clinical exam. When they come and work on the floor, they've got a unique insights. They've got more knowledge, as you said, and they appear to be more confident. And that's why I think it's not unusual for certain hospitals to prefer the candidates who have got AMC2. They are the hospitals which are mostly, in urban settings. And they prefer the doctors who have done AMC Clinical 2. So it gives you an edge in terms of job preferences. 30% of the doctors who've done AMC Clinical 2 will find that they've got many more hospitals that they can apply, which are exclusive to the candidates who have passed AMC Clinical 2 and not just AMC Clinical 1. So if you have got, I think, a little bit of job, career gap, and little bit meaning 3 months or less, but you have got a recent AMC Part 2 pass, then you've got much better chance of passing or getting that job, provided you do well in your interview. As Dr. Ruhi was saying, it improves your confidence because you're showing that confidence, you're demonstrating that skill set, that, confidence is not just, appearing very smart or over smart. It's about showing trust in your way of thinking, in terms of taking the history, in terms of making a diagnosis of differentials. And that's what confidence is. That oozing of the confidence really demonstrates and cements that relationship and rapport with the patient. Now, obviously, you're not going to stop here. All of you have passed exam, Dr. Zoe, Dr. Ellie, Dr. Ruhi. You might be doing more exams in the future. And I think I often say that licensing exams are very unique. They are basic exams, which gives you a taste of local exams. So whether you're doing, Australasian College General Practitioner exams or critical care exam in emergency medicine or any other exam, they're built on the same framework. So it somewhat improves your understanding in terms of disciplining yourself when you're preparing, in terms of appearing and doing the whole, nuances of the things. So it improves your understanding to the local exam. So definitely, if you got a chance, do that. I always say that if you've got a chance between a WBA or clinical, go with the clinical. Obviously, WBAs are not easy to get. Those jobs are hard to come by. And the trusts on the hospitals right now, they would really like to waste a lot of time. So even if you were to get into a WBA program, because there's so many applicants, they won't give you that job easily. They'll say, okay, why don't you work with us for at least a year? And then we'll reprioritize and get you in. So don't waste time. If you prepare yourself, be organized for at least 12, 13 weeks, you've got a decent way in cracking this exam. Now, so I call our strategy plan, prepare, and pass. We advocate for passing all stations. Now, it may sound optimistic, but it's quite usual. And I think Dr. Ruhi and Zoe and Ellie may agree that most of the candidates who fail would have at least passed 8 or 9. Isn't that so? They tend to fail by a narrow margin, or not a huge margin. Let me put it this way. But any fail is a fail, obviously. So we often say to all our participants, aim to pass each and every station. And if you take every station as an individual exam, you've got a much better way of conducting yourself. So when you're done with a station, just forget about it, move on to a next station. So pass all station, taking each station as an individual exam. It's all about disciplining yourself. So if you've given yourself 3 months, staying in a routine, and we'll do a Q&A session about how to organize your routine. But I think having a routine with your job and family commitment is quite personal, and you're the best judge of that. Like what times work out for you in the morning, in the afternoon, late at night, it's entirely up to you. But make sure that timetable is repeatable. It's not like you're doing 1 revolution per day. Tomorrow I'm going to finish half of the Murta, or I'm going to do that, I'm going to do this. It's not like that. It's about keeping small chunks, every day without fail. So you must have a routine. The other thing is that, when you're attending course, any course, not just our course, the course is to be akin to your exam preparation. Utilize this course as a real exam. So we have got lots and lots of role play, of fresh recalls of some of the old but very high yield topics. And there's a lot of feedback which is going to be coming from Dr. Zoe, Dr. Ellie, and Dr. Ruhi. Take that feedback constructively during the course. So when you're doing the course, proactively jump onto the role play scenario. I want to do that. Okay, don't back off. Have your camera on, have your audio obviously on, and do those scenario under exam conditions and get that feedback that, look, this was good, this was not good, and this is how I'm going to work on it. Now, I also say that, look, when you've got a chance, do as many trials as possible, because trials are the one which are going to get you out of your comfort zone. You might find that you're okay with the physical examination station. You might find that you're okay with the communication strategies. You may find even that you are fine with some of the others, but there would be certain stations that you're not comfortable with. And these trial exams, which are done according to the exam conditions, they really expose that area. That, look, this is the area where you need to strengthen your, weak areas. And that should be done way ahead in terms of exam. Now, this is the approach that we often talk about a lot, that always start by reading a task. Some of the questions can be very long, very complicated, and very convoluted. You don't want to be completely absorbed into a scenario. And sometimes there might be a few things which you don't really understand by just reading the scenario or a question alone. But the task really highlight the important bits of that scenario. So read the task quickly and then jump onto the questions. Sometimes the questions could be as long as half a page or full page. And whilst you've done that, you're actually proactively thinking what Dr. Zoe was saying, that plan your diagnosis and come up with the differentials as well. And then plan your task. Like, my task is to take the history. My task is to counsel the patient in terms of contraceptive advice, in terms of, alleviating their concern about a rash and the differentials of a rash, or some of the other bits and bobs. And finally, when you're inside, as I'm saying, that when you're doing face-to-face, when you're inside, make sure that your rapport is, seamless. It should be almost formulaic to start off with, but it should also be adjusted to the scenario. So, because, it's very easy to use the same commentary over and over and over again. But you don't want to do that. And I think this is a skill which the courses really help you with, because you'll be doing many scenarios. And if you're able to, have 2 or 3 different approaches of introducing yourself, having a lovely opening statement in regards to a patient who's completely distressed and distraught, then it will really help you. Let me just see if there's anybody. There's few more people. I'll just add them in. Sorry about that. So introduce, check for the comfort, make sure that you ask permission. If you think the patients are unstable, check for the stability. Developing a rapport is all about checking the analgesia, making sure the parents are there with the pediatric patients, making sure if there's a patient who is distraught, then you take those concerns on board. And I'll show you some of the quick, very simple words to build up on that rapport strategy. Now complete the task, whether it's got to do with the history, complete all the portion of the history in terms of past medical history, in terms of drug history, social history. Don't miss allergies. Don't miss any bit, because you will be demarked if you miss an aspect of the history. And it's just not about, taking a blanket history. It's about being specific to the scenario, because you've got a certain amount of time. I tell you one thing, which I often say. If I would say that you have got 20 minutes to do the same scenario, trust me, all of you will pass without a shadow of doubt. But the idea is to actually do all of that within a short span of time. So you have to be very economical, but at the same time, you have to complete all the components of the history. Same goes with examination. Make sure that you've got the consent, make sure the patient's got an adequate level of analgesia, and you're doing the local examination, systemic, cardiovascular, respiratory, neurological, whatever the demand of that scenario is, you're doing that completely. And finally, the investigation. We often talk about bedside tests, the laboratory tests, the radiology tests. It's a good way of really organizing your brain, because in the heat of the exam, you may skip a few things, but if you have that pattern, you won't forget. Open up a wide differentials. At least you should have a plan that this is my working diagnosis. This is what I think is wrong with you, most likely based on the history examination. I remember I used to work with this orthopedic surgeon when I was an intern back home in Pakistan. And he had a very unique way of telling us how to come up when talking to the patient. He said that whenever you're talking to the patient, say, based on the history examination investigation, I think this is the working diagnosis or a problem. Having said that, we would also need to look into this other problem. And I often used to say in orthopedics, there's no differentials. They're either a broken bone or not broken bone. But he obviously, not teaching us just the orthopedic. He said that, you need to prepare yourself through a wide variety of situations. If the patients come in with a joint pain, it could be arthritis, it could be septic issue, it could be, early rheumatologic issue. So make sure that you're in tune with that kind of strategy. And then, management is that aspect that we often tend to forget. We think that management only comes in last, and we are very good at it. Like you do ask for analgesia early on when you're starting the scenario. That's also a part of management. So you're breaking the bits of management and using them throughout the scenario. Sometimes the patient's quite distressed and, crying, and you're really consoling them at that point. So that's also very good that you do that early on. But one of the most important thing about the management, which I find is a little bit challenging, is when you're talking about the last bit, that this is the management plan, then it's important to talk it in terms of heading of general management, which is mostly the symptomatic care and control, is specific management in regards to that disease, and then follow-up advice and patient education. So make sure that you do all of that and don't miss those things. And finally, give the patient a chance to ask any question, give them any information, and give them that red flags, what we call that. If that's something like that happens, then you more than likely. So that really demonstrate that doctor. So I'm going to show you a scenario, and I'll just quickly go through. We've got certain participant. Is there any participant? I'm not doing the scenario. I'm just going through some of the highlights in terms of. So this is a physical examination scenario. So if I was to start doing this scenario, I'll start off with the focused physical examination of the lower limb. You've got a picture. Everybody can see that picture, right? All right. So we got that picture in which we got two lower limbs, and we are meant to be examining those lower limbs and then answer any question by the examiner. These are my tasks. And the history or the scenario or the question is about a 65-year-old gentleman by the name of Henry Carrigan. And he's come to the GP clinic with complaining of swelling of both his legs. Yes, they do look a bit swollen. His right leg seems to be slightly more swollen and painful on walking. And he is a chronic smoker. So there are plenty of clues out there. And what I want you to do is think about what could be the possible differentials. If you think about that red light, green, traffic light sign, we've read our task, and while we're still in that 2 to 3 minutes of thinking period, then I'm thinking of, oh, yes, it could be when I'm examining this patient's lower limb, it could be lower limb chronic venous insufficiency. It could be arterial insufficiency. It could be DVT. The other differential could be cellulitis as well. So I'm thinking about all those strategies in terms of examination. There might be something wrong with the toes and ankles and knees in terms of musculoskeletal issues, but then these are the questions which will come up during when I'm examining the patient. All right, this is just a very quick schema to run that, but I'm going to go more through in terms of specific issue now pertaining to the history. Okay, so whenever you're taking the history, then obviously, needless to say, you need to check for the comfort. You need to make sure. I'm not talking about the last scenario that was about the examination. That was just there in terms of a random slide, but I'm not more focused on the history. So I've broken that down, the history taking aspect, into a few more things. So whenever you're starting the historical session after introduction, make sure you always confirm and you make sure that patient. So one of the ways that to confirm the identity. So you're Nancy. Nancy, how can I help you? So that's often a very good strategy. Instead of why you're here, what brings you to the hospital, that's also fine. But that opening statement, how may I help you today? Always couple that off with this question that I believe that you've come in with some leg pain. I believe that you've come in with some chest pain. I believe that you've come in with some concerns about a rash or some questions about your pills. How may I help you? So that whole strategy of knowing something about the history and then, building up on that is that first aspect of developing a rapport. Then screen for symptoms. If it's a historical station in which you're meant to be establishing diagnosis based on the history and the facts, then screen for symptoms. If you've got any particular specific to that scenario. So if the patient's come in with the, shortness of breath, screen for symptoms. So tell me more about, shortness of breath. So start off with the open-ended question. So you've got some shortness of breath. Can you tell me something more about it? And the patient would be very specific in terms of, oh, yes, doctor, I have been short of breath for the last 3 days. I've noticed that it started off with a mild sore throat and then it evolved into a cough. That is more pointing out towards a lower respiratory tract diagnosis. But you can have another scenario in which you may have a strategy in which, okay, fine, doctor, I have got a shortness of breath, which is more exertional. It gets more difficult when I'm walking or climbing up steps. Can you hear me clearly? Can you hear me? Can you hear me all right?
Fine.
Can you hear me?
Yeah, we can hear now.
Okay, perfect. I don't know what happened. As I said, my connection can be a bit unstable. So if I drop out, just let me know. Dr. Rizwan, we can't hear you. So right now I can't even see your face. But if you can see me, that's okay with me. Can you see the slides?
No, we can't.
No, doctor, no.
Okay, all right. Just give me a second. Sorry about that. Just give me a second, please. We had a bit of a hiccup. Just give me a second. Okay. Right. Share screen. Can you see the slide now? Yes? Okay, perfect. Okay, I think I've gone back a little bit. Okay, finally, then gathering information. As I said, open-ended question. Listen to your patient. They will give you most of the diagnosis themselves. So let your patients do the work. And there are different strategies in terms of when you're taking pain history, when you're taking, shortness of breath history, when you're taking, any other complaint history. There are different strategies, there are different tools, there are different mnemonics. One thing which I'd like to highlight is once you've established the key information in your history, always check back with your patient. So while we're doing the scenario, we can have that strategy is that if, patient is, so I believe that you've come in shortness of breath, you've also said that it is associated with chest pain and it's radiating to the jaw. That's a final summary. Let's take it further about in terms of planning. So reinforcing the key information back to the patient, if you've got time, that is really a good way of giving you an idea as to what's going to happen in terms of planning of investigation or planning your management. And ask if missing anything. Is there anything else on your mind which I may have missed? Technically speaking, in AMC, they would not give you an information which you have not asked for. Okay, but you can say, is there anything else? Is there any other concerns that you may have? And they say, oh, doctor, I'm just worried about that. What's wrong with me? What's my diagnosis? That is what they're highlighting. So have those little quirky ways of cutting through the lot of the slack if you're completely clueless. Finally, if your history is more pointing out toward the cardiovascular, neurological, or venous thromboembolic, then you have to ask for the constitutional signs and symptoms of cancer, venous thromboembolic risks, cardiac risk factors into the hypertension, smoking, and peripheral vascular disease. And as I said, system review are also important in terms of shortness of breath, palpitations, ankle swelling, dizziness, syncope, if you're talking about cardiovascular problems, and constitutional symptoms, as I said, in terms of malignancy. As I said, meeting the patient expectation, concerns is also important. And finally, complete all the components of the history taking. Okay, so this is a very quick summary of what I've just quickly got through to put that all into a context. I know I'm going over time. Sorry, guys. I'll just take you on board. We're just about to start the case. So Mr. Raphael Hien is a 78-year-old retired accountant who is presented with the symptoms of weakness of his left arm and leg since yesterday. Initially, he disregarded his symptoms as they were mild, but today morning, the weakness in the left arm and leg is worsening, causing difficulty in mobilization. He's got a heart rate of 112, temperature of 36.6, and blood pressure of 110/80, and SATs of 98%, and the blood sugar of 6.7. Take a history from Mr. Kian, and what is your diagnosis and differential diagnosis? So based on this strategy, I think the most obvious differential which is coming to my mind is, no prize in guessing that one, is whether he's got some sort of neurodeficit, whether he's got some sort of stroke type symptoms, whether he's got a TIA. And there's a bunch of risk factors which might be there. So when I'm taking a history, I'm very specific to the stroke type symptoms. So Mr. Rafael Ken, my name is Rizwan. I believe that you've come in because you're particularly concerned today with your left arm and leg weakness that started yesterday. So thinking about the stroke time cap, so the presentation within the first few hours has already missed that boat. So it might not be categorically in that, symptoms of stroke only or TI only. It might be to do with something with a space occupying lesion. It might have to do something with the bleeding, or it might have to do with some other strategy, like if it's associated with the headache, it could be hemiplegic migraine. So thinking about that broad range of differential. Now, based on those differentials, how and which differential becomes a specific history is more important, which is the bits and information which are going to come and reveal themselves in the history. I haven't really had a chance to check Yes, yes, my connection has been a bit unstable. Can you all hear me right now, right? So someone's check your connection if you can hear or not. Anyway, moving on further. This is an atrial fibrillation. This is a slide which I just put out there to highlight the point that this patient is more likely to have a stroke, in which most of the patients have got an underlying atrial fibrillation, which is another pointer to could it be a delayed presentation of a stroke? And how can we further work him up from that point of view? Now, top 5 mistakes before I wrap my bits, having a too much of a formulaic approach. And I know when you do lots and lots of scenario, you tend to develop your own style, but have a few styles. Just don't stick with one style only. Make sure that you're answering the task and not wasting time on some of the other non-important bits and bobs. And, there'll always be certain things which are critical. There are critical errors which will let you not pass that. And the idea behind the critical errors is that you do lots and lots of scenario, and you will always know, particular to that scenario, these are the errors which I'm more than likely to make. And finally, you've got no rapport. Some of the people I've seen, they're just too much in a way of getting the task done and over with. And there's no feeling, there's no emotion involved. So even though it's very artificial, I know, whether it's online, whether it's face-to-face, and you might be very anxious, but it's always a point to give at least 20 to 30 seconds to have that kind of, approach to make sure that you're connecting somehow with the patient, the parent, or the subject in that scenario. Nervousness is good, but don't let that completely overwhelm that. I'll just get, in the interest of the time, I'll get the tutors to start off with their cases, and then we'll talk a little bit more about at the end in terms of portal or any questions that you may have. The portals, in fact, I might just quickly cover. So we've got this portal, which is only for you, the course participants, and it has got notes, the latest references from most of the Australian guidelines and websites. And it's topic-wise, it's organized, it tracks your progress in terms of a progress bar. So these are just not videos, these are videos with the progress bar. So wherever you leave it, you'll start off from that same end. Yes, all your CPD certificates are downloadable from student dashboard, and all the new videos are automatically uploaded once you've done your session. So this is a very good tool, very good strategy, and it will help you plan your 12 weeks while you're doing your course with us. And you can jump on the website right now, emergencyfocus.net, and have a look at some of the trial sessions which are already up there in terms of the portal and any other things. So let's start off with, so this is the inside the portal. So as you can see, all of the sessions in terms of introduction, pediatrics are all organized into different chapters. This is how the scenario looks like. It would be running through the timestamp. So the time would be running to give you an idea. So if you're doing a scenario, you can mute the scenario and you can just practice that scenario by yourself. And then the feedback would be below. So this is just all the topics are on the left side. When you click on a certain topic, it would be on your right side, and below the scenario, there'll be all the notes and explanation and guidelines. So it's a complete tool. So no matter what notes and other things that you're following, this is a very extensive resource which we've built up on all our courses, which have been previously conducted from all the various different tutors. So it's got a lot of data and a lot of resource there to go through. And yes, so I'll start off with the scenarios, and this is a scenario for a rash, and I think Dr. Zoe is up for it. So can I just ask for any volunteers who would like to do a scenario? It's not time capped. We're not judging you. So anybody who would like to do a scenario, please raise your hand and we can give you a chance. Anybody who would like to give it a go? Dr. Ruhi, can you see at your ends the participants? I don't know. I can't really see the participants at my end.
Yes, doctor, I can see them.
Is there anyone who is
No.
raising a hand or would like to raise a hand?
No, sir, I cannot see anyone.
Okay, all right. So look, I mean, this is a free session. We're not being judgmental here. Nobody should be. Dr. Zoe, how about you start and we'll take it from there. If somebody wants to pitch in and give their sort of input, more than happy for you to join in the middle as well.
Okay, so hi everyone, and I will start with the first scenario. So I hope in the between, if you want to chime in, just please let me know. Otherwise, I just gone to what I'm thinking when I read the same and how I build the approach. Okay, so the case with 25 years old girl has had a rash for a few hours. He has a recent history of viral but respiratory tract infection as well. The vitals are stable, respiratory symptoms are stable, are normal as well, and no swollen lips. So when we gone through the task, we can think, okay, this is a 3 task, and you can think the time may be run out. So we take care of the time management. And I also think of if I have the history, like they said that for 6 minutes or because I took the online one, so 4 minutes or 6 minutes. But when I see the history with the 6 minutes, I reckon that this is the prominent assessment. So because there are variety of the global score, and each of the score that even you get 4 or 5, but the global score, which is the examiner point of view that you want pass the case, if you don't meet the prominent assessment. So whenever you read the case, especially you can see the history 4 minutes or 6 minutes, this is the prominence, which means we put more efforts on the prominent task, okay?
Excellent.
So when we read the case, so we think, okay, this is the rash. So in our course, we try to collect all the cases related to the rash, and we call it a cluster. So we divide it into the rash with fever, with most likely for the infection cause, the rash without the fever. So we have the set of the diagnosis and also the differential. So when we do the course with you guys, we try to make you think of as a habit. Okay, this is the rash without the fever. And this is make you feel less nervous because when we jump to the case, it's less likely that you think much of the differential as when we practice, okay? So for on the history, as Dr. Rizwan introduced, I also divided into 3 parts. So the first one would on the introduction, make the patient comfort, build the rapport quickly. And then the second part would explore the trip complaint. And the last is just like wrap up the case with past history, the social history, or the SATMA. So whenever you have the history, you focus on the second part, which is how you approach the symptoms. Like I'm thinking of, okay, this is the rash. For all the symptoms, I'm thinking this is the onset, like since when did it happen? How did it start? And is this the first time you have it? So apply it for all the cases. And we think, okay, so when you get the characteristic of the symptoms, so for example, Dr. Rizwan said we have the point for the chest pain with the mnemonic. Okay, the pain with shock rate. So for me, I build the same approach as well. So for the rash, I also build the mnemonic for the rash. So just quickly, on the feature of the rash. And then with that information, so you come up with the working diagnosis. And then the second part is to rule out the negative part, to rule out the differentials. Okay, so let me quickly illustrate what I need to ask in the history for you. How can I move to the next slide?
Yeah, sure.
Okay, just some instruction of the role player, which means when you can use this information when you practice with your role player or your study partner, okay? So just quickly, can I have another slide as well? Okay, so In this case, I just want to start with a characteristic. As I mentioned, okay, the timeline, when did it start? How did it start? Is it the first time you get it? And the second part is the rash. So when the rash appeared like mnemonic with the SS, CP, PIP, and DOP, which means the S for site. So where is it? Where the rash start? The spreading. How does it spread to other part of the body? It's extremely important for the pediatric case because when it start with the rash over the body and then the spread throughout the arms and legs, it's different from another part. And C for the color, B for the blanchable. Patient can understand blanchable, so you can say that, okay, when you press on the skin, does it turn into the normal skin color, which is the way we ask about the blanchable, and is it palpable, which means it's flat or it raised. I for itchy and painful. DOP, which means like you can remember day of birth, but it's not. It's like any discharge, any oozing, any bleeding from it. And you ask something about the infection, like any fever, any flu-like symptom recently, or any redness or hard to touch over the skin that we think of, though, is it just like the simple rash or the rash with the infectious size, okay? And the last question, like any rash over other part of the body. So this is where I build the mnemonic for of the symptoms. Some complicated symptoms, otherwise you don't need any specific mnemonic. It's the style, okay? And then I move to a part like cover on the SADMA, the past history, the medication history, but in each of the symptoms, each of the point is really important. So for the rash case, I focus on the history of the medication and also the history of the allergy, or the asthma in the history of the personal and the family history. So not only in the case that you ask on the SADMA, but some of the key point in the SADMA is really important depending on the case. Okay.
So what was that mnemonic, Dr. Zoe? You saying that I think it was a very good mnemonic.
So you move, can you move to the next slide? I also have this in the slide. The next slide, please. Sorry. Oh, maybe I don't put it there, but I will repeat it in the chat box for you that I SS CP DOP is.
Okay, so sorry, hang on.
Okay, I type it on the chat box.
Okay.
If I can say it, yeah.
Okay.
I repeat it again. S for site, now the S for spreading, C for color, P for blanchable, P for the first P for palpable, I for any itchy, P for painful, DOP like any discharge, oozing, any bleeding.
Okay, fine, got you.
Any like any infection. S another S for any skin change like hard or redness and anywhere, which means other rash of anywhere of the body. So this is the mnemonic. So whenever I have any rash, I don't think much in the exam. I just like ask all the questions that I have. Yeah.
You know, when I was preparing for exam, I had that many mnemonics. I would remember the mnemonic, but I wouldn't remember the contents of the mnemonics. They were all confusing. So I'll just go back to your slide. I think you had some critical errors in terms of your particular scenario. You said that not ruling out anaphylaxis. Now, I had a question there that in terms of anaphylaxis, it's a true diagnosis, like it's a very emergent diagnosis. So I think in the scenario, there might be some relevance to that in terms of OBS or anything like that. It would be an emergency scenario that look, the patient's looking unwell, he's pale, diaphoretic, he's got a generalized all over body rash with tongue, lip swelling and eye swelling. Anything else that the participants can do to check on the spectrum of whether it's a mild allergic reaction or an angioedema or an urticaria or a full-blown anaphylactic scenario with this anaphylactic shock? In particular, reference to the online when you haven't got much in a way of, what's in front of you.
Okay, actually the stem is quite clear. I mean, there's a long stem. I remember there's like the full stem with all the information. But in this case, even though they can at the stem they say vital are stable and no swollen, they might give you the clue. It's not the anaphylaxis, but there's some the clinical error if you don't rule out this as well. Like first of all, we check the vital sign, and I was gone through, I've gone through any respiratory symptom, any abdominal symptom because it's really important. So whenever I have the rash case and without fever, and I like automatically rule out the anaphylaxis first, and I think it's the good habit that we don't think much in the same,
Yeah, no, that's very important. And you're right, 30% of the anaphylactic shocks, they do present with GI symptoms, so diarrhea and vomiting. So it's very good, even though they may not sound relevant, but yes, they are very relevant. Okay, all right, moving on.
And then for the allergic reaction, it's really important that you figure out the triggers because it's not maybe come from anything else. So maybe we have the list of the triggers. I also mentioned that any infection sites in the same, they say had the recent history of the upper respiratory tract infection, or you can have any medication, any food, any exposure to any cosmetic, some of triggers that we remember. What I want to point out is, so when you have the rash, you don't have any fever, you need to rule out 2 steps. The first is the rule out the anaphylaxis, and the second key point is to find out the trigger of the allergic reactions. So that is the part of the the positive finding for the working diagnosis.
Perfect.
And then the negative findings to rule out differential. So in this case, another slide, I point out some of the differential.
Okay.
There is one, can you help me with, the next part. The previous slide, I'm sorry.
The previous one, sorry.
Yeah, this case. So we already have 2 key points for the working diagnosis that I mentioned. This is a rule out the anaphylaxis, and the second to find out the trigger of the allergic reaction. Then my task is to rule out the differential. So anaphylaxis, we already rule out. Erythema multiformis. So you can ask just 1 or 2 questions. Like most of the case, they have the target skin on the arm and also any ulcer in the mouth. So you don't need to ask all of the list, just like, do you have any ulcer in the mouth? I say no, okay, keep move on. Dermatitis, like you can add any allergic like history of a skin problem before, or you have an exposure to new cosmetic. Okay, no, let's move out. So SLE, we have any joint pain. Okay, no, move out and move on. Leukemia, any loss of weight, loss of appetite, blood bomb around the body. And that's just like only one question.
One, exactly.
Yeah, just one only. And you show the examiner to say, okay, I have the differential in my mind, and I try to prove I don't have like based on the recall only.
This is very good. So just by one question, you're excluding one differential diagnosis or including one differential diagnosis. That's excellent. And the actors are precisely trained to respond to that as yes and no. Yes, as a matter of fact, I do have joint pains if you're alluding to fact SLE. And then you can build further on based on other questions. Oh, which joints are involved? Tell me more about it.
Yeah, that's right. Yeah. Whenever we have positive finding, we dig in. This is the habit. Yeah.
All right. Okay. I'll move on to your next slides.
I want just like we also have the approach for each of the tasks. So whenever it's a differential of diagnosis and the differential, so we don't make effort to explain a lot about the condition and everything. Just one sentence for each task. Like, okay, diagnosis, we follow 5C as a popular mnemonic for everyone to take the AMC, what the condition is. So you can say, okay, based on the information that you gave me, most likely you have the allergic reactions. And then what happened is caused by when you expose to the new thing in the environment, such as in this case, maybe the food or the insect spike. So you take the positive finding that you have in this case. So for example, this case with the food, okay, which the food that you consume, and it's just a normal things, but it can have the symptoms like you correlate with the positive symptom in your case, like the patient have a tingling around the mouth or the rash. Yeah, and just move on. And then whenever you explain the complication, it's really important that at the moment we don't think that you have the severe form of the allergic reaction, which is anaphylaxis. It's not only for the patient, but it's only for the examiner as well, because they think, oh, you need to because you are safe doctor, and then move on. So I think just one question, one sentence for each of the case that you cover on the necessary thing. And in your mind, you think what you're gonna say, because in the environment of examination, it's really important that you guide your brain what the brain should think. So this is the way that I approach.
Yeah. All right.
And then the next slide, just like briefly talk about the management plan. I just want to, some people like they may, we have the controversial issue related to what the medication, should we name it or not? I do believe that, okay, you can say antihistamine is still good. Like pick up one popular thing, like you just remember one name, just show examiner that you know exactly what is it, but just not only, oh, everyone say antihistamine, but you say cetirizine, it's make you outstanding. And in the borderline 3 or 4, these are the point that they put you on 4.
Agree with you. Yeah, so that's really demonstrating your practical knowledge, that you know the name promethazine, phenergan, cetirizine, as you said. At least you don't have to come up with a dose or strategy, but at least that we can give you orally, or if the reaction is sort of moderate to severe, along with this antihistamine cetirizine, I'd like to give you a short course of steroids starting with 25 milligrams. And obviously, as you said, giving an adrenaline. So that's very good point. It's actually shining up and showing and exploiting your information from our practical know-how. It's good. Yeah, I agree with you.
Yeah, and for each of the case, like try to learn some key point only. So for example, I sum up with a case with I do with you in the way I learn. Okay, this is the rash. In the history, I just remember what the characteristic of the rash and what the differential with the rash. And each of the key points to rule out my differential. Okay, move on. The diagnosis, okay, it's an allergic reaction, 1-2 sentence to follow the 5C approach. And then for the management plan, this is, okay, I remember antihistamine with cetirizine, if doesn't work, single dose of steroid. And important triggers, you remember the triggers, okay, avoid all the triggers. And then one of the important thing is anaphylaxis. So whenever anaphylaxis, you remember action plan. So for the anaphylaxis and also for the allergic reaction. So yeah, that's why it's make it simple for each of the case and you don't get overwhelmed.
Very good. Excellent.
Yeah.
Has anybody got any questions for Dr. Zoe? Anything else that our tutors, Dr. Ruhi and Dr. Ellie, would you like to add on? No, I think we'll move on then in the interest of the time. I've got scenario number 2. I think Dr. Ellie, that's your case. Perfect.
Yes.
You may start. So again, I'll just ask if somebody wants to have a go. I don't feel they want to have a go. So you can just highlight what you are, what angle have you got in that case?
Okay, sure. Thank you. So this case, I selected, it looks easy, but it could be very tricky sometimes. It depends to the gestational age of the pregnant lady and the positive points in the history, the diagnosis can change. I mean, the case is the same, but the diagnosis could be different.
Yep.
So the tasks, if we just check, is history, physical exam, and explain the condition and management. So it's nearly everything. So we are in the ED, and the young lady, which is pregnant, obviously, is 34 weeks, and come to see us because of vaginal bleeding since last 1 hour. So because the patient comes with bleeding, it's important that we check the vital. So make sure that the patient is stable. But first of all, at the same time or before that, we need to introduce ourselves and saying some comforting words to the patient. So because patient is obviously is worried about baby and herself at the same time. So we have two patients at the same time.
Yeah.
So it's important that the patient feel comfortable and reduce her stress a bit. And then, before, I mean, in that 2 minutes that we think, we need to think about our differentials before we see her. So bleeding, it could be with pain or it could be without pain. If it's with pain, so we need to think about premature labor. It could be premature labor, or it
that's fine. Yeah,
because it's a late pregnancy. Yeah, it could be abruptio placenta because it's also with pain, and but abruptio placenta has two types. It could be with bleeding or without bleeding. So we call it, if it's with bleeding, we call it revealed. If it's without bleeding, concealed, which is the bleeding cannot come out. It's just accumulate inside the uterus. Another thing, it could be placenta previa. With that one, they have only bleeding without pain.
Okay.
So we need to rule out any trauma, any accident. And yeah, and then the physical examination here and history is very important because the diagnosis is just with them. So could you please change to the next slide?
Sure. Yeah.
Thank you. So after all of those introduction that I mentioned, we start the history. So pain was positive in this case. So the pain, we need to dig it more. That abbreviation Socrates. So we need to make sure that the pain is continuous or on and off. How much is severe? If the patient is really in pain, we need to offer the painkiller. That's really important. And at any time, if we feel that patient is not stable, we need to inform the senior doctors and specialists because it could be very serious. And so Socrates, quickly, we ask most of or nearly all of the questions of that. And then about vaginal bleeding, we need to ask about the amount, how much, when, so we know when it's a start. We ask that is about the volume of the bleeding or about the how much is severe. We need to, we can ask how many pads did you use and they're fully soaked or no. And about the color, about any clot, because that shows the severity as well.
So any pad change, which is like an hour fully soaked pad with clots substitute or suggest that it's a heavy bleeding, right?
That's right.
Yeah.
That's right. And also the color, any other discharge, regardless of bleeding, like any water, any discharge. And then if patient feel dizzy, that's also showing that the blood pressure is not stable.
That's true. Yeah.
Any trauma or any falling, any motor vehicle accident, anything. So we need to address them, ask them. Any fever. So this patient had didn't have any trauma, no fever, so infection possibility reduced. No discharge, so again, infection possibility reduced. And any toxemia sign like preeclampsia signs and in the symptoms. And also baby is the other patients, so we need to make sure that patient feel the baby's kicking. If not, we need to ask when was the last time that you
that's a very important point that you've said in terms of well-being of the baby, because this patient's 34 weeks. The strategy, especially if you're dealing with preeclampsia, the definitive management is to have an early delivery by cesarean section and emergency cesarean section. In terms of well-being of the baby, what are the key questions that you can ask to ensure about the baby's, well, one, you said that it's kicking, movements, anything else?
Yes, other thing that we need to make sure patients was regular with the antenatal screening before.
Okay.
And if everything was normal so far, like any blood test, that if she did any ultrasound, especially 20 weeks ultrasound, and any abnormality, any background medical problem the patient has, because all of them can change the scenario. And in physical examination, so it depends if you're doing online or face-to-face is different. But if face-to-face, we need to ask the examiner. If online, they just give us the card. So the physical in the vital sign was stable, and abdomen is a bit tender. There was no contracture, no rigidity, and no guarding. And FHR was normal. And in pelvic examination, cervix was closed. So here we don't have any task for investigation, but if we had, we need to ask the examiner. But we can, because we don't, we have the management, we can cover this part in the management part. And in the rest of the history, we need to cover support, because especially in pregnant ladies, it's very important if they have support or no. In some cases, especially in placenta previa, it's important that how long patients live, how long live to the hospital. And in case that we want to discharge him, her. And also the support is if she has constant companion or no, always. And also SADMA and any past medical, any past surgical, any quickly think about 5P as well. If any past, is it the first pregnancy or previous pregnancy, any past complication with the other pregnancies as well.
That's good.
And so that's the history and physical exam. And in the management, so now here with this information, we can understand the diagnosis is the abruptio placenta, because in the premature labor, the pain is on and off and is not continuous. And in the
abruptio placenta.
But we need to explain to the patient that it's just our diagnosis, our provisional diagnosis, and we need to confirm it with investigation and also by reviewing of a senior doctor, a registrar. So we need to do an ultrasound to see the degree or severity of the condition, and also we need to do some blood test to make sure that if she need any blood transfusion, or if she need any other more tests, like we need to check the Coombs test, especially if patient is Rh negative, and then go from there.
Perfect. So in terms of the main key differential diagnosis, it's premature labor versus abruptio placenta. And you said the continuation of the pain is more favoring the diagnosis of abruptio placenta as opposed to premature labor, in which the pain can be intermittent and off and on, as you suggested. And obviously from the other red flags, you need to make sure that you quantify the bleeding You need to quantify the symptoms of dizziness and postural syncope, so postural blood pressure. If the patient's got low blood pressure, and then take it from there. And then you've obviously got this range of tests for the Boson maternal test and CTG for the well-being of the baby to make sure that the baby is okay. Because if there's any frequent decelerations, then the part of the management plan, very important part of the management plan, would be an urgent cesarean section.
That's right.
Okay.
Anytime that the patient is unstable or the baby is in distress, or if bleeding increase, then they may decide about emergency cesarean.
Okay. So one of the most important things that you've said, which we haven't covered here, is support. Now, can you tell us more about what does that mean, Dr. Ali?
So support means because pregnant ladies need support because during pregnancy or even after delivery, lots of things can happen that is not predictable. So they need always help. Not always, but sometimes, but they cannot predict it. So support is very important. Especially if they're alone or if their husband working outside, far away from them, then they need support. We can arrange for social workers if they don't have any friends or relatives.
So one of the things that you can incorporate whilst taking the history, that I believe that you've come in with the PV or vaginal bleeding and you're very concerned about it. Do you want me to call someone or ask someone to call your husband or partner? Is that okay? And the actor may respond, yes, my husband is on the way. Doctor, I'm fine with that. At least demonstrating that social aspect, the support aspect, as you've highlighted from pregnant women, is very important. Perfect. No, I agree with that. Do you want me to move on to the next slide?
Yes, please.
Perfect.
Thank you.
All right. So we'll move on to the next slide. That's what we've talked about.
Yes, I missed the second one. So the fibroid is one of fibroid is always diagnosed in the ultrasound if the woman had a fibroid before. So if it was positive, it's one of our differentials because it doesn't happen during the pregnancy. Normally, if they have fibroid, they have it from before. And the main diagnosis is premature labor, placenta previa. But as I said, because of the pain and bleeding, approaching placenta is fit better.
Perfect. Okay, we'll move on to the next one. Okay.
So this is critical errors. I'm not sure all of them are criticals, but they're error. If we don't do, it's not good. So not checking hemodynamic stability of the patient, especially if the patient is in bleeding. So we need to always, this is in our priority. And then not appearing empathetic and or any comfort words, like if we speak like a robot and we don't, we don't, because they're really stressed, especially it's not about themselves, it's about their babies.
No, that's a very important point, because sometimes under all that stressful environment of that we need to get through the task, we become quite robotic, as you said. So it's always, worth to take a step back and just say, okay, are you with me? Even saying small things. Do you understand so far what's going on?
Exactly. And pain also here is important, especially if they're not, they cannot tolerate it. We should offer painkiller. And admitting the patient here is very important because we are not sure what's the diagnosis, what's the severity. So we need to admit the patient and start the IV fluid. That's the first thing that we need to do, even before the registrar come, because if they come, they expect we already do this. And not consult with the senior or with the registrars or specialists. It's not a good thing. We should consult with them. And management not offered as monitor the patient and baby both at this. Because we have two patients with ultrasound and CTG, and anytime if baby is in distress or if bleeding continue, we need to emergency cesarean. But if the bleeding is stopped under the decision of a specialist, they can go home, but with some measures like they need to rest more and they need to follow the specialist. And always we need to be with the reassuring sound, we need to speak. Even in the serious, very serious condition, still we need to reassure the patient, because yeah, if we give them more stress, it's not good.
Yeah. Especially when you're doing face-to-face exam, you've got to think from the point of view of empathy, that what would happen if this patient, you have to put yourself in patient's place, that what would you expect? How would you expect to be treated? All right, good. Thank you very much for that. And I'll jump on to, you've got some specific things that do you want to talk about that? Or are you okay?
I just put here a picture about difference of placenta abruptia and placenta previa, but I'm sure everyone knows.
Okay. Yeah. So these are the late vaginal bleedings, late pregnancy vaginal bleedings, and you've just sort of highlighted how the normal placenta is placed, and in terms of abruption, what happens, and in terms of previa, it's completely obstructing the birth canal, and how the bleeding can be so torrential from that point of view. Good. Dr. Ruhi, you may like to. And I think the mental health is one of those areas where there seems to be always a lot to ask. The most of the diagnostics are based on the history. So it's really important to establish those key questions whilst also making sure that the patient is safe. So yeah, take it, please. Thanks.
Yeah, thank you so much. Hello, everyone. So we are going to do another case, which is from psychiatry. And this case is from handbook. The reason why I included this in the introduction, because like handbook cases are also very important. In the exam, you will get at least like 3 to 4, I assume, yeah. So try to read the handbook cases. And as you know, like you have to read your task first and your scenario. Because in some of the handbook, like most of the handbook cases, you can see the stem is very long. So in order to save your time and to help you, so start reading from the task. Like if you read the task first, like it's written, evaluate the situation by taking a focused history, then outline to the patient the nature of the problem you have identified and propose management. So now you have to only take focused history, because most of the information will be given in the stem itself. Yeah. So then you can manage your time. Like you can think mentally, like I have to give like maybe 2-3 minutes for the history. The rest of the time should go to the next task. So now after reading the task, go to the stem. So what it's written, like you are working in a general practice. So you have to keep this in mind, that you are in a GP practice, not in hospital. So you saw this patient, Samantha. So actually I have cut short the stem. The stem is very long in the handbook. So you have to like practice so that in 2 minutes you can cover or skim the stem, and you can also go with the task as well. So you saw this patient, Samantha, for the first time 1 week ago, and provided a prescription for her usual sleeping tablet, which was benzodiazepine, oxazepam. So this is a short-acting benzodiazepine. So patient was taking 30 mg daily, 25 tablets. At that time, you were satisfied that there were no comorbid problems such as depression. Patient was okay. Now again, patient returned for another prescription. So patient came again after 1 week. So you have to think at this time, like why the patient came again after taking 25 tablets. So it could be a dependency. Okay. So in that, so you have to start like, can we change the slide, sir?
Sure.
So these are some of the instructions given for the role player in the handbook itself. So like the role player will say, doctor, I will be just give my sleeping pills and I will be going. So patient won't be concerned about any other thing. The patient will try to give you some fake story. Just he want to get away with the tablets. And if you try to build trapo, or if you try to like ask more questions, but patient won't be cooperative. So this is also a indication that patient is having some dependence. And another indication is that patient will know the name of the tablet, the dose of the tablet.
Yeah. And this is a very common scenario in hospital scenario as well. So we from the practical point of view, the patients who are opioid dependent, they will come asking for Nandone. They will come asking for OxyContin or any other like fentanyl. So you're right. They will be very specific in terms of what they need. And that can often be the first clue that they've asked, that the GPs are closed. That's why they've come to the hospital. They've run out of their benzos. They've run out of their opioids and they need a prescription. So they would be doctor shopping, in other words, with very specific medication.
Yeah. So these are the instructions for the role player. That this is a woman, 25-year-old, and you were prescribed this anxiolytics 4 years ago when your marriage broke down. At the same time, your business failed and you were having problems. So these are just the, like, if you go through the handbook, you will know all the story. So this is just the story of what happened to the patient. Like, patient was taking anxiolytics and patient was getting a good sleep. And patient will also give a history that the patient was having some depression at the time, and doctor started this medication. Eventually, the patient got dependent on this medication. Now, work, relationship, home life, everything is okay. Can we change it to the next one? Okay, so this is the framework we have to follow, which we will be teaching since the day one. So you have to read your task first and read your question, then establish your all these things. So we will go through it once again later. Next slide, sir. I cannot change it here. Okay, so you are generally in good health. You do not smoke and drink alcohol. You do not have any serious illness, injuries, or car accidents, falls, or any faints or loss of consciousness. So what this instructions or information is giving, like, you have to derive the information from this, and you have to ask the history while you are practicing. Like, for example, for any psychiatric case, you will start with offering confidentiality. And in this case, you have to be very empathetic. Okay, and the most common dependency cases, like in AMC, will be like benzodiazepine. Another is heroin, morphine. You will also get smoking counseling and alcohol. For all this, you will start with, like, other tutors also told, and Dr. Rizwan also mentioned, that the history of presenting illness will be like, you can elaborate the mnemonic Socrates, like how it started, how long you were taking this medication, what was the reason, after, of course, calming down the patient, reassuring the patient, and after maintaining confidentiality, because patient won't be interested. So it's very important to have like, calm down and build rapport with the patient. So this will be the history of presenting illness. Like, you have to ask, like, how long, how often, and why. Then most important questions we have to ask in every dependency case is like tolerance, dependence, and withdrawal symptoms. Along with along with that, you also have to ask about the dependence, motivation, how motivated the patient is. So for tolerance, you have to ask, like, since you have started this medication, like, have you increased the dose? So patient will say yes. From this information I'm saying, the patient will give history. Yes, I was taking the medication once previously, then I need to take twice a day, thrice a day, or so this will be for tolerance. For dependence, you will ask, like, like, if you have missed your dose, do you get any withdrawal symptoms? So obviously patient will have any withdrawal symptoms. So here, if you read, you can know, like, I was occasionally taking half a tablet, or I have missed the tablet 1 or 2 days. I was feeling edgy, jittery, shaky, unable to concentrate or sleep. And one day I thought I'm going to have a heart attack because my chest was pounding. So these are all the symptoms or withdrawal symptoms. So if the patient is obviously having withdrawal symptoms, that will indicate the patient is dependent. Okay. Then along with that, we also have to ask, like, few questions from heads, like which is already given in the information, like how is his family life, social life, how it is impacting his daily work, relationships. So it's very important. And also short psychiatric history, like how is the mood of the patient, because from the stem we know that patient is having a history of depression. So even for, I think for any dependency drugs like heroin, morphine, they can cause depression if as a side effect or as a withdrawal effect. So it's very important. It's very important to ask the short psychosocial history, which could include like mood, suicide, delusions, and hallucinations.
Now, one question I have, Dr. Ruhi, is that even though the scenario does not suggest any history of self-harm or previous suicidal ideation, is it still important to quickly screen for suicidal or self-harm risk in this kind of scenario, given the history, there's a history of depression and marriage fail and all that?
Yeah, because I think because of previous history of depression, it's better to ask simple questions.
Okay. Yeah. Have you had any thoughts of self-harm or?
Yeah.
Okay. Homicidal ideation.
Yeah. So head and past medical history, all those things. So this will be your focused history.
Yeah.
Can we jump on to the next slide?
Yeah, sure.
So here the main thing is your management. So you can follow the 5C approach here as well. Benzodiazepines are usually recommended for only short-term use, but this patient is taking it for a long period of time. Maybe there will be a history of 1 year use. The patient will be taking since 1 year or 2 years, whatever. So usually it is only given for long-term in chronic severe anxieties or other treatments, including along with antidepressants. But if the patient is taking for a long period of time, then you have to explain, because you're taking this medication for a long period of time. And if you're not taking, you said like you are unable to concentrate, you are unable to sleep. That means I'm feeling that you are dependent on the medication. So try to, we have to avoid saying that you are addicted. So that will be judgmental. So I think we should avoid saying that you are addicted. Rather, you can redefine or you can rephrase by saying that you are dependent. By using the same symptoms or same features the patient is giving. Like patient will say, I'm unable to concentrate or sleep. So because of this, we are thinking that you might be dependent. So here we have to suggest that we are going to plan. So this plan will include, like we will gradually reduce the medication. So there are short-acting medication and long-acting. So the medication you are taking, oxazepam, it is a short-acting. And this medication, what we will do, we are going to gradually convert it into another medication, which is long-acting, like diazepam. So, and you won't get any withdrawal symptoms like you were having. So if the patient will say that I was having some faints or fits or fever, irritability, so you won't be having this, because we are still giving you the medication, but we are going to gradually reduce this medication, at least like 10 to 15% per 2 weeks. So I'm going to give you medication only for 2 weeks, and you have to get it from the pharmacy. So yeah, so this should be the plan. Yeah.
The other thing I was saying, maybe you've already mentioned, I may miss that point, is a quick history in terms of checking for illicit drug use. So lots of patients who are on dependency, we must always check, like they've got an alcohol dependence, how much they're taking in terms of standard drinks. Have their usage gone up or down, or have they mixed and matched with any other recreational drugs in terms of not over the counter, like street drugs, any hallucinogenics, any sort of mushrooms, or any other toxic intakes of heroin or injecting or orals, speed, ecstasy. Yes. That's also very important.
Yes, definitely. Sorry, I missed that. So we have to ask the other smoking, alcohol, and other drugs history as well, because it can worsen the situation. So it's very important to address those things as well.
There's one more thing which I was thinking of, Dr. Ruhi, that situational crisis. So if this, like you mentioned, a very good point of depression as a background, whether there could be financial issues which are further compounding the problem. So remember, as a whole, obviously the drug aspect is only an aspect of their problem. There might be something else going in the background of, you said that drug-induced psychosis, drug-induced problems in terms of recreational drug use, smoking, alcohol, and other recreational drugs. Could they be financing, lack of housing, breakdown of relationship, as you've just said, or loss of job, or taking the kids custody over? So they might be triggering more dependence. I like the word dependence, or reliance even, that you might be more reliant because there are some pressing circumstances in your case which is causing that. But how about we work it out together as to what could be the best strategy in terms of solving this as an issue, and keep you in a close follow-up. Sorry, were you saying something?
No, definitely, sir. So I think that will be included in the heads when we elaborate all the family history and all the relationship and work.
You're right. Yeah. So that you said heads and mnemonics, very important. Perfect.
Can we change it to the next one?
Yeah, sure. Oh, did I miss the slide? Hang on. There we go. Sorry.
Okay. So from the handbook, I can see that there is no particular, mistake or any critical error. But I think we cannot, if the patient is on a short-acting benzodiazepine, we cannot abruptly stop it. We have to gradually reduce it, and also
very good point.
With frequently monitoring the patient. And we have to also give patient other like alternatives, like if the patient is taking this medication for a sleep problem, so we have to also we have to teach the patient regarding the sleep hygiene.
Yeah. So that's very important. I think this scenario in particular is littered with critical errors in terms of history, establishing what they're on. Have they gone up on their dose? Have they gone down on their dose? Have they been compliant with their dose? Are there any other alternatives that they're relying on in terms of adequate sleeping? Is there any other trick in terms of reliance of alcohol or recreational drugs? So there are quite a few things which we must make sure they're there through all those mnemonics in terms of heads. In terms of at the end, do you think the management strategy of referral to a psychologist or psychiatrist might be? Yeah.
Yes, that is the next thing I've
slide.
So we have to refer the patient for the behavioral therapy as well. So if you can change the slide.
Is that the slide that you're looking for?
No, the next one.
Okay, sorry. Yeah.
Okay, yeah. So we have to provide alternative to benzodiazepine, that will be the sleep hygiene. So few things you can say regarding the sleep hygiene, but if you think the time is not sufficient, you can keep it at the end. Like you have taking bed at the same time, avoid caffeinated drinks, take warm shower, do exercise, all those things. So these things you have to explain, but you can explain at the end. But the main thing will be how you're dealing with the benzodiazepine. So, yeah. So you have to discuss the sleep hygiene and behavioral interventions. For that, you have to refer to the psychologist.
That's very good. And melatonin is very good. Melatonin is very good in terms of inducing. It's not a maintenance kind of thing, but in terms of inducing the sleep, it works synergistically with other strategies like sleep hygiene, as you said here.
Yes. And even like if the patient gives underlying depression, so mirtazapine will be good. So it will be effective for both depression and insomnia.
Yeah.
And like while you are taking history, you can also ask to the patient like which one is the most concerning or most concerning withdrawal effect. Sometimes the patient can have tremors.
Yeah.
So if they get the tremor, we can even prescribe beta blockers, propranolol for the physical symptoms.
Yeah.
Or if fever, we can give analgesics like antipyretics. So accordingly, symptomatically, we can treat. This is for low risk.
Yeah.
So low risk, we can go with alternative. Will be sleep hygiene, behavioral therapy. This is also for the high risk. For high risk, we are going to gradually convert it to the long acting and gradually reduce it.
Yeah. No, that's important.
So can we change it to the next? So yes, so this one I was talking. So benzodiazepine for moderate or high risk, which means the patient is taking it daily or the patient has tolerance or dependency. like the patient is getting any withdrawal symptoms, or the patient is taking more than the prescribed medication, then that means the patient is having moderate to high risk. And in that case, you have to reassure the patient that we are not going to stop this. You won't be getting any withdrawal symptoms, but we are going to give you the other medication, which will be diazepam, which will be a long acting. You still get the benefits of the medication. And at the last, we have to taper it and completely stop it. So that will take some time, but throughout this journey, we are going to be with you. So this is the thing. Yeah, and you also have to offer some additional support, like you can refer the patient to the drug and alcohol service if the patient is especially dealing with some withdrawal symptoms.
Yeah, no, that's good.
Yeah,
which we've talked about, like drug and alcohol service is very important, because somebody has to keep them under a close follow-up, especially if we've identified that there's a breakthrough issue in terms of drugs dependence, alcohol dependence. That's very important. And the reason I say that, like when I'm working on the floor, even in emergency, these seems to be a very common cause, that the patient have got benzo dependency, and they're trying to compensate or overcompensate by relying more on alcohol, which is, as you rightly said, often makes the situation from bad to worse. So not addressing that aspect, which might be the underlying cause, you might not be solving the entire scenario. So that in itself could be a critical error.
Yes. Can we change to the next slide? So these are some of the examples. Like in the exam, usually you will find the short acting. I used to remember as OTA, like oxazepam, temazepam, alprazolam. And long acting, what we are converting it to, most common will be the diazepam. So you can also remember the other names. And yeah, if you like, you can remember this midazolam, alprazolam. So if they can change the scenario or the drugs as well. So if they give you again that very short acting midazolam or alprazolam, still the case will be the same. You are going to convert it to the long acting one. So you can remember from this. And the most common, like OTA, like oxazepam, temazepam, and alprazolam.
Yeah, that's very good. And that's important, because even in like talking about another scenario in terms of alcohol withdrawal, most of the hospital guidelines now recommend oxazepam as opposed to diazepam. So even though you may have a patient on diazepam, but there are more long acting, and they've got much more in terms of respiratory depression and other side effects, as opposed to oxazepam, which you can more frequently give, more repetitively give, so less chance of side effects in terms of respiratory depression, drowsiness, and obviously reduced level of consciousness from that. So these short-acting medication for alcohol withdrawal are also something to consider. Okay, all right. Next slide.
That is it, sir.
That is it. Okay. All right. Has anybody got any questions? Dr. Ruhi, if you have got anyone who can come, and we just about finished the scenario and all of the scenario. Has anybody got any questions for Dr. Ruhi? I think if anybody has, then I'll just stop sharing here. Sorry. I think we're all good. We'll stop the recording here. And thank you guys all for attending. I really appreciate you taking time and attending some of the questions. If you've got any questions in terms of upcoming course, please send me an email, info@emergencyfocus.net. Our formal sessions will start, I think, in first week of February, and then we'll take it from there. All right. Thank you very much, guys. All the best. Have a nice weekend, whatever is left of it. And I'll see you at the course. I myself would be coming in the course as well. Thank you. Bye.
Thank you, sir.
Bye.